Interdisciplinary teams are things that we've talked about a lot in class, and I would say that a strong interdisciplinary team can lead to positive experience and successes for both patients and for professionals. So across various disciplines, including occupational therapy and physical therapy and speech therapy, we can work together to strive for the best kind of care in these positive experiences. And we've talked about how each professional has a very unique and important role in providing these patients with the best care possible. And we've started to realize and really see how many of these goals and outcomes are related across the disciplines. And so when we look at occupational therapy specifically, I would say that the role is to help a person transition back to home and back to their daily life activities, whatever their participation may look like. And so we have a unique opportunity to focus both on rehabilitation and prevention because we are building someone's skill sets so they are able to return to those things, but that can look a couple of different ways. It can include home programs, it can include patient education, it could include caregiver training, all for that rehabilitation, but also for the prevention of re-injury. So generally interventions for an occupational therapist focus on your basic ADL, so bathing, toileting, hygiene, and dressing. But OTs have that unique ability to match the treatment to each patient. So their goals and treatments are really going to match the person's personal ADLs and how they complete those ADLs. And so things that an OT may focus on would include activity tolerance and energy conservation techniques, fall prevention, safety awareness. Safety is always first, and a lot of times that begins with patient education and OTs observing. Beyond that, home modifications. This may mean environment modifications or adaptive tools, equipment, that kind of thing. And then pain management and adaptation with further adaptive equipment. In terms of a physical therapist role, they are definitely looking at that functional mobility. So, and generally, it's more of the lower body, but interventions may include or focus on strengthening in general, balance, and possibly wound care. And so the goal of those interventions are to promote a person's ability to move and restore that functional ability and hopefully decrease pain as well. And beyond this, it may also use or include the use of an adaptive device or a front wheel walker, as this case mentions. And so in general, those goals are really focusing on the strength, the balance, and the activity tolerance to allow for that functional mobility. And then for speech therapy, their specific role or goal is to address those swallowing disorders, cognitive deficits, speech language, or communication difficulties. A large piece of that is education, and so education to patients, education to caregivers, and even education to other staff about swallowing. And so this case, interventions might specifically be looking at difficulty with swallowing to meet those nutritional needs, and specifically safety with that to avoid any negative choking, aspiration. We'll talk about more of that later. As well as cognition in general. So when we look at an intervention or treatment plan among these three disciplines, I would say that co-treating is very appropriate. In general, you have that ability to work as a team to really find the best goals and the most important goals. And so then if you're not always able to work together, it's okay, because in the back of your head, you know that the other therapists have the same priorities on their mind. And knowing that all your therapists are on the same page is really beneficial when you think about maintaining and building that relationship and trust with your patient. So for them to see that you're all on the same page, all cheering them on, all working to help them to return home, that really just creates a great environment. And then when I think about this case specifically, and Pamela specifically, co-treating is definitely ideal for a patient that experiences a lot of fatigue, just because receiving 3 hours of therapy throughout the day might not be realistic. And so if she is able to see 2 or 3 therapies at a time, she'll be able to conserve that energy and hopefully feel better throughout the day, maybe participate a little bit more when family's there, when nursing staff is there, that kind of thing. In terms of some specific interventions, feeding is one area that I think all three disciplines have a role in, and an important role in. For occupational therapists, it's looking at that proper posture, how they're using their hands, usually the upper extremities, but beyond that would be the use of adaptive utensils and maybe even cups as Pamela starts to work on grip strength and in-hand manipulation. And for a speech path, it would be looking at proper swallowing mechanisms to avoid choking or aspirations, as mentioned. And beyond that, really looking at and understanding if there's a need for dietary modifications, and then they would further consult with dietitians. So you see how it becomes an even bigger team. And then I think a really big thing would also be education, and to kind of start the tie together things for understanding, to say how you eat affects your energy, which affects how you are participating throughout these things. So nutrition leads to eating, which leads to your success with OT and PT. So just really explaining that to a client so they understand how all three things are really intertwined. And then as a physical therapist, you may be looking at proper posture and activity tolerance to be able to complete the meal. When I think of grading, I would say if a patient is extremely fatigued or brand new to therapy, it might not be appropriate to co-treat all three interdisciplines at once, just because it may be best to begin with speech to not overwhelm them. In the case it was mentioned, that Pamela was frustrated related to feeding, and so when you add in sit this way, use this adaptive device or cup, and we're thinking about swallowing, it might be a little bit too much. And so that's just one thing to consider. And another thing that grading up and down will be different for each discipline. So not everyone will grade up at the same time or grade down at the same time, etc. And so physical therapists might think about sitting versus standing. OT may think about taking that built up handle off or leaving it on, longer spoon, a different shape of silverware, that kind of thing. All of it is leading back to that speech path's opinion on swallowing. And it may be even choosing a different food item. So cutting steak is going to be harder to cut, but then also, for hand dexterity or strength or whatnot, but then also swallowing if that's safe. Another intervention or common goal would be basic ADL, so bathing, toileting, hygiene, and dressing. I feel like both OTs and PTs have a great role in that. OTs primarily looking at energy conservation, adaptive equipment use. So between those two things, it may be staying seated, maybe building up your toothbrush. It may be forming routines so you understand I need to do these things first in the morning when I have the most energy. For a physical therapist, it may be looking at postural control, balance, and then general activity tolerance, and maybe really focusing on trying to increase your endurance. And then both disciplines are going to really look at safety and decreasing those risk of falls, and part of that would start with smooth transfers. In terms of grading down adaptive equipment, sitting would be one thing to simplify a task, maybe even taking breaks, and then to grade it up, make it a little bit harder, it would be maybe increasing the frequency, how many times a day these things are done independently, or maybe it's increasing the complexity of clothing. So instead of a simple t-shirt over your head, it might be buttons, or maybe you switch to a zipper first. Pain management is another intervention that both OTs and PTs I feel like would be working together on. OTs may be looking at that pain or mindfulness technique, breathing exercises, versus that PT is going to work with OT to come up with the right level of exercise that's encouraged. And so we know that energy is related to pain, and that exercise may relate to pain management. And so grading up and down really is based on the level of exercise that is recommended. It might be increasing amount of breaks or decreasing, and then also this might be important to add to a routine to just ensure that that pain management is incorporated before the pain is too hard to bear or too hard to even engage in any other activity. Lastly, I would say fall prevention, home modifications, and safety. Very generalized, but this is something all three disciplines can be involved in. For OTs, probably most specifically would be home modifications, looking at adding grab bars or shower bench. For PTs, it's looking at that proper gait mechanics and proper use of the front wheel walker as they're ambulating throughout the home to make sure that transferring and mobility is safe to prevent that further injury. And then for a speech therapist, something I really thought about was cognition, just because I feel like I've mentioned education multiple times. And without that cognition piece, if we do not realize that there's a cognitive deficit, it's hard to say if that education is really going to be transitioned to home. And so a speech therapist can kind of take note of cognition and see how that transition to home, how the cognition may affect that, and if the education has really been absorbed, and if someone is safe. In terms of grading, I wouldn't say it's necessarily important to grade up, just because these precautions are for fall prevention and safety, and there's no reason to remove those barriers or those benefits. But another grading option would be that adaptive equipment, or a device. Maybe it's changing back to the single point cane or staying with a front wheel walker, or even transitioning to a wheelchair. In terms of communication strategies, it's really important to have clear and open communication and roles between the therapists. Number one, encourage each other, recognize their strengths, have a positive relationship firsthand so that open communication is strong, and then you feel comfortable to define those roles. Those things really carry over to care for a patient. They can feel and see relationships, and likely how your relationship is among you three will likely carry over to the trust and relationship that you have with your patient as a group and singularly. In addition, I would say that spending time with the patient to build that relationship is really important, singularly and as a group, as I kind of mentioned. But then spending time to also educate the patient on how your treatments are related and how they're working towards goals, so they really understand and see the connectedness of the disciplines and your goals. Just further motivation, benefit participation, that kind of thing. In terms of communicating with hospital professionals or nursing staff or even families, I would say one thing, you could post the routines or priorities for energy conservation if Pamela feels that's necessary, whether it's when she returns home or puts it on the wall to say, hey, I'm not just saying this because I'm tired. My therapists agree we should do X, Y, or Z. Another thing with energy conservation, I would say potentially asking the family or caregivers for help with delegation of tasks. Having a therapist bridge that gap might be easier to ask for help that way. Otherwise, when I think of basic activities of daily living, I also think about routine and really considering how that might be best for the home environment, and talking to caregivers may be a great way to think ahead and really make a plan that makes sense for Pamela. And then also I think about the use of adapted devices and talking to staff and caregivers on what we're using, why we're using it, and how it may change throughout Pamela's progression. So in general, I would say in most cases, everyone would benefit from co-treatment in terms of knowing that everyone's on the same page and working together. Granted, it is a case-by-case scenario, but I feel that as a professional, you can only benefit from having another person's support and thoughts and strengths. And I think Pamela's situation is a great example of how all three disciplines really need to work together and can work together.